Thanks so much. So my name is Kyle. I'm one of the family doctor hospitalists at the Pasqua, and my project was looking at opioid prescribing practices at the Pasqua Hospital. And I think like most of us, I started out, you sort of see at the bottom of the slide, my original aim statement that I went into CQIP about was all about trying to reduce IV opioids. Because in my mind, if we could stop using IV opioids so much, we would be able to solve the opioid epidemic. And I got linked in with some really good people, and I started working with the opioid stewardship team actually over at the General Hospital. And eventually the revised aim statement after a couple of PDSAs and a couple of cycles of improvement changed to just being able to get some baseline data, measure the appropriateness of opioid use at the Pasqua, and then hopefully feed this information back to the doctors on the accountable care units and see if it would improve the appropriateness of opioid prescribing. We were hoping to have this done and have PDSA cycle go through, and then COVID happened. So it's still on hold, but at least I have some baseline data, which I'm excited to show. One of the other big pieces that I also really liked about going through this process was I ended up meeting a lot of like-minded people. And this is a driver diagram that Sarah Todd, she's one of the nurses over at the Pasqua, and she's a site manager, helped me to develop. And this is just all about trying to reduce opioid use in general. And you can sort of see, if you follow down to care providers, the secondary drivers would be to potentially modify opioid prescribing practices. So definitely only tackling IV opioid use would, of course, only tackle a very, very small percentage or problem of the bigger opioid problem that I think we're facing. So going through this process led me to realize that you shouldn't lead with your solution, and helped me make some really cool connections. Some of our initial results were looking at pre-admission opioids. We saw that the majority of patients actually came in with no opioids, and then the second most common was hydromorphone. One of the neat things is, out of the 7 physicians we surveyed, the red line shows the morphine equivalent, so anything less than that is actually appropriate. So overall, we're actually doing pretty good, and there seems to be just this one provider that got dragged sort of higher for a number of reasons, but overall, we were doing pretty good with opioid prescribing. One of the other key factors we looked at was whether or not we used the oral route versus IV or sub-Q or another route entirely. And the chart on the left is a logarithmic scale, so you can see that the oral route almost has 2,000 orders wrote versus the IV medication route was only 190, which was a good learning point for me as well. And one of the other pieces of data we were able to obtain with the team we assembled was just all about discharge length and how often we prescribe opioids on discharge. Most of the time we don't, which is good to see. But then an interesting piece for me was actually when we do prescribe opioids for discharge, we're usually prescribing them for greater than 7 days, which a lot of the guidelines suggest we shouldn't be doing. So my key takeaways from this project were, don't lead with your solution, which was a huge one for me, because if we would have only focused on IV opioids, we would have only caught 9% of all opioid prescriptions out of, well, obviously all the other opioid prescriptions. But when you look back to that driver diagram, we would have seen I would have been only tackling a very small portion of the problem. And just going through the process made me realize that there's way more to this than we think. The other cool part was developing that team was definitely essential. So I worked with the opioid stewardship department, which had some amazing people in it, Sarah Todd, and we got to go through that process map process with her. And then I was actually able to work on a Suboxone and opioid withdrawal PPO with some of the other colleagues I met, which was very cool. And then my last piece is just opioid prescribing is complex, and it has lots of moving pieces. But right now we actually have some pretty good baseline data that I'm hopeful we can start using for future PDSAs and comparing to the baseline data. And I think the next step in my mind would be trying to tackle those discharge prescription lengths, which I hope to try and do after COVID. So it was a good journey, and I appreciate it.